Chapter 31, the musculoskeletal system. There are three types of bone cells. Osteoblasts are responsible for bone growth by making new bone cells and secreting collagen. Osteocytes regulate mineral uptake and release. Osteoclasts dissolve minerals for release into the bloodstream. The human skeleton is made up of a total of 206 bones. Ligaments join the bones of a joint together. Tendons are connective tissue that provide joint movement. Cartilage is a form of connective tissue in which fibers and cells are embedded into a semi-solid gel material. Cartilage acts as a cushion, and an example would be the meniscus in the knee joint. A bursa is a fluid-filled sac that provides cushioning at friction points in a freely movable joint. Skeletal muscle is made up of hundreds of muscle fibers that are bundled together and surrounded by connective tissue. Fascia is connective tissue that surrounds and separates the muscles. Skeletal muscles are attached to the bones by tendons. The bone in the body is maintained by remodeling. Existing bone is reabsorbed into the body and new bone is built by osteoblasts to replace it. There are age-related changes. Ossification, or the replacement of cartilage by a more solid bone-type tissue, is not completed until ages 20 to 25. Bone density decreases because of the reabsorption of the minerals. A loss of bone mass or osteoporosis occurs and is more severe in women. Bones become brittle and less compact, and they break easily. Bones do not heal readily after fracture because of the physiological exchange of the minerals decreases with advancing age. It makes repair much slower. There is a thinning of the intervertebral cartilage and the collapse of vertebrae that can cause kyphosis. The joint cartilage will thin and erode from years of use and result in stiffness and crepitation, which is the grating sound heard at joints. Joint motion may decrease that would limit mobility, and swelling may occur. Ligaments become calcified and will lose their elasticity. There is a decrease in muscle mass, the cells decrease in number, and the muscles atrophy. This causes less strength and endurance. Tendons shrink and they become sclerotic. This slows the muscle movement. Muscle cramping at night increases due to the impaired circulation and accumulation of metabolic waste. Healthy People objective was to reduce hospitalizations related to osteoporosis-related hip fractures. Adequate amounts of calcium and phosphorus are essential for bone growth as well as density. Although many green vegetables are a source of calcium, that calcium is not readily absorbed. Dairy proteins like cheese, yogurt, milk are better choices. Non-dairy sources of calcium can include sardines, salmon, tofu, figs, and dried apricots. Magnesium and vitamin K are necessary for healthy bones as well because these are provided by a healthy diet that contains meat and green vegetables like spinach. Smoking has its own significant effect on the bones and joints because it increases the risk of developing osteoporosis, the risk of hip fracture, the risk of exercise-related injuries. It has a detrimental effect on healing and a detrimental effect on athletic performance. Individuals need an intake of calcium so that way the levels remain within standard parameters. Total calcium should be 9.0 to 10.5 milligrams per deciliter. Phosphate or phosphorus should be 3 to 4.5 milligrams per deciliter. Alkaline phosphatase, or ALP, should be 30 to 120 units per liter. Creatine kinase, or creatine phosphatase, in males, it should be 55 to 170 units per liter, and in females, it should be 30 to 135 units per liter. Uric acid, males should be 4.0 to 8.5 milligrams per deciliter, and females should be 2.7 to 7.3 milligrams per deciliter. For physical assessment, we need to notice posture. So is there evidence of kyphosis? Are knuckles swollen or deformed? We look at their gait. Is the gait steady and even? For balance, is the patient able to sit, stand, and walk with a good center of balance? For mobility, is any supportive device being used or necessary? Range of motion. Is the patient able to move neck, shoulders, arms, and legs with full range of motion? Strength. Are the grips in the hands and the push-pull in the arms equal? Is the straight leg raise against resistance equal? Is there any tenderness of the vertebrae of the spine? How do the joints appear? Are they red, deformed? Is there a loss of motion in elbows, hands, knees, ankle, or feet? How do the skeletal muscle appear? Are there any signs of atrophy? Is the patient able to perform their own activities of living? Each person that is involved with the move of the patient, including the patient, should understand exactly what is going to happen and how the procedure of moving will be accomplished. As nurses, we need to explain the long-term benefits that will increase the cooperation with our patients, because we know that this will help preserve the skin integrity of the patient and decrease respiratory problems when turning and moving. As nurses, we want to prevent disability, so we will use different interventions to assist our patient to maintain their mobility, whether it be exercise, diet, family assistance. Whatever the patient needs, we try to help them. The continuous passive motion machine that is seen in this image encourages joint mobility. As nurses, we want to increase gradually the mobilization of our patients. We use exercise and range of motion, whether it's passive or active, and we use isometric exercises for the patients. We want to ensure that our patients understand how to ambulate with assistive devices, and we want to ensure that they understand if they have a removable sling or a splint, that they know how to reapply it appropriately so as not to cut off circulation to the fingertips. When nurses evaluate, they look at the effectiveness of the treatment or the interventions. We want to make sure that we observe the patient to see if they can perform activities of daily living, including ambulation,